I'd like to welcome all of you here who have already joined, and I'm sure just in the next few minutes, if a few others will join here. Welcome everybody to our latest Mental Health and Substance Use Protocol Programme National Learning event. The event is the main title is Crisis and Out of Hours Care and Safe Spaces. Today we will be joined by Emma Wilson, who's the Senior Service Manager for Penumbra, who will be giving a presentation, and Claire McDermott, Mental Health Primary and Unscheduled Care Team Leader from the Scottish Government. So we're really looking forward to hearing from them. Thanks everyone who could be here today. Please introduce yourselves and just a few words about what brings you here in the chat box. And it'd be and tell us where you're coming from and your backgrounds in terms of your professional background. And it would be really helpful to know about in terms of our protocol and the learning programs and exactly how this might be relevant to the work that you do. There will be time for questions and answers later on, and I'll just hand over to my colleague Benjamin McElwee just now.
Thanks. Next slide, please, and I'll just take you through some of the housekeeping slides. So yeah, if you have any technical issues, then please contact Abby from our team. Either send her a Teams message or an email if you're having any difficulties seeing the slides or any difficulties with sound or something else. Then please do get in touch. We'll try and sort that out for you as soon as possible. Next slide, please. And here's some instructions just on how to use Teams for those that aren't familiar. I won't go through all of them, but it tells you how to open and close the chat, how to access live transcription, how to turn your camera on, particularly during the Q&A. That will be disabled whilst the presentations are happening, but we'll turn them on during the Q&A. Same for your microphone. And there's also instructions for how to leave the meeting, which is normally how we troubleshoot in the first instance. Ask you to leave and rejoin. So next slide, please. Here's some instructions just about the Q&A function. So as Champreet mentioned, there'll be time for questions and answers after the presentations, the 3 presentations that we have today, and here's some instructions on how to use that. So when we come to the Q&A, we'll ask the questions that are in the Q&A box first, and then we'll come to hands, and then we'll do a bit of alternation. So if there's anything that comes to you during the event, then please do ask your question using the instructions there. Next slide, please. And just to let you know that this session will be recorded for those that aren't able to join us today. But we won't be recording during the Q&A section. And I'll hand back to Champreet just to run through the agenda.
Thanks, everyone. We're just going to start shortly with a presentation from Emma Wilson from Penumbra. I just wanted to just read out shortly just a short statement in terms of trauma-informed care. We know that a lot of yourselves attending today work in substance use and drug and alcohol services or mental health services, and we recognise that we regularly work in quite emotive context, and there may be content today that includes accounts of personal experiences across mental health, which may be triggering. And it's important that we look after ourselves. So if at any point you need to take a break, please feel free to do so. If you would like to ask a question more privately, you can email us instead of using the chat box as well. We'll just move on to our presentation. First, we've got sorry. Benj, I'll hand over to you and you can take over.
Thanks. So I'm Benjamin McElwee, Senior Improvement Advisor for the Mental Health and Substance Use Programme within Healthcare Improvement Scotland. Thanks a lot to the speakers for coming along today and for all of you for your interest in this topic. I'm just going to use this chance really to promote the national protocol and to kind of emphasise the links that are within that relate to urgent care for people with co-occurring conditions. So next slide, please. So this is just a reminder of the protocol and the areas that it covers. We have been piloting a self-reflection tool with some areas to help them understand how their local protocols relate to the national protocol that's out there. And I guess I thought it would be useful just to mention that the national protocol includes kind of numerous references to the kinds of things that would support effective delivery of out-of-hours care pathways. For instance, ensuring that staff, including staff working within the third sector, are appropriately trained according to their level on assessing and managing co-occurring conditions, that local mental health and substance use systems are visible, that they're connected, and that they're considered in other areas of improvement, redesign, and transformation that might be happening within local systems, of which urgent mental health care pathways might be one. That there's mechanisms for information sharing across partner agencies, that there's established escalation processes from substance use services into urgent mental health care pathways, and that services enable fluid transitions to cope with the fluctuating needs that are often experienced by people with co-occurring mental health and substance use. So next slide, please. And whilst the presentations today will kind of really talk about that crisis point that people experience, I thought it might be useful to think about the opportunities before people reach crisis as well, or when they're heading towards a crisis or at risk of one, where there could be things that could be done. So acknowledging the system pressures that services are currently experiencing, the workforce challenges in terms of recruitment and retention, capacity issues. There are also things that can be done around proactive identification, proactive management and intervention, and proactive follow-up. So in terms of identifying risk, there may be people that are at risk of harm, and risk factors to look out for might include non-engagement in employment, significant life stressors such as bereavements or job loss. For people known to services for a while, there might also be factors like anniversaries that precipitate harmful coping strategies. And I guess it's just to say that a curiosity about what's going on in the lives of people that are being supported can lead to these opportunities to intervene before a crisis arises. And there may be cohorts of people that are either known or unknown to mental health and substance use services who frequently attend A&E or have frequent contact with other emergency services. And again, there might be work that could be done within local systems, including the third sector, to work with blue light services to identify these people and to look at the underlying causes of their frequent contacts, and then to provide some of that more intensive support that might be required. In terms of assertive outreach, again, to those that have gone missing, in a sense, those that are no longer attending physical health appointments, or those that are no longer attending routine substance use appointments, those that have experienced a non-fatal overdose, those that have attended somewhere in crisis like an A&E. The kind of recent research around missingness found that patients with only mental health conditions who missed more than 2 appointments per year with their GP had an 8-fold increase in all-cause mortality compared with those who'd missed no appointments. So again, this is a group that are likely to be at risk, and there might be work that you can do in your local systems through that interagency collaboration, through sharing information across services so that the relevant services are informed about disengagement or fluctuating needs to enable some of the proactive follow-up. And another example might be kind of joint responses to crisis by both mental health and substance use services. And I'll bring our clinical lead, Shampreet, in here just to see if there's any examples from her clinical practice around any of those things in relation to proactive identification of people that are at risk, proactive management and intervention, or proactive follow-up.
Thanks, Benj. And I think anybody that works in mental health or drug and alcohol services will be familiar when patients start to become more and more unwell, or things are starting to grumble on, indicating that there might things that they might reach a crisis point soon. And there's always opportunities to intervene. Usually there's indicators, there might be more phone calls, out of hours, perhaps to NHS 24, or in hours to their key workers, or duty services. And there is lots and lots of positive examples with all the daily activity that goes on with crisis teams or home intervention treatment teams, perhaps to get involved, compassionate compassionate distress response services, or in fact they're key workers trying to de-escalate things if things are very difficult. And as Benj mentioned, it could be specific triggers, whether it's a death anniversary, or perhaps their drug or alcohol use has reached very, very unmanageable levels. It could be debts owed to drug dealers. And these are just very real scenarios that happen every day. And sometimes people become acutely psychotic, or their mood dips to a certain point where they can't see anything else, and they become acutely suicidal. And I guess the real bridges for these scenarios are your crisis teams, or your home intervention treatment teams, and facilitating further assessment to mental health assessment units, or safe spaces where they can access the right treatment. And I suppose it's important to think about it within hours and out of hours, because out of hours it can feel um, a lot more difficult when there's skeleton sort of services available, and that includes public holidays. But there's real opportunities to intervene to help prevent admission to hospital or things becoming more and more difficult. And sometimes individuals require admission to hospital if things reach a very, very difficult point. And I suppose the bridges between that and opportunities to intervene, and if there are things that can help in the interim, whether they have a housing difficulty or they've become homeless, or they require more support from family, then a lot of key workers and staff work very hard to help with these situations. If it gets to the point where individuals need to be admitted to hospital, I've certainly worked with staff who have spent hours, for example, on the phone to dog shelters to try and get dog and cats accommodated. So there's so many different elements when trying to de-escalate a crisis, or in fact appropriately escalating if somebody needs to have further assessment. So I hope that kind of contextualize it a little bit, and we can hand on and hear from our first speaker, Emma.
So it's just one final slide for me, I guess, to tee up what Emma's going to speak about. So I guess in an ideal world, what we want are these crisis pathways that are inclusive, holistic, and maximize intervention opportunities. So inclusive in the sense of inclusive of people that are experiencing distress, who might not have a formal diagnosis and therefore might have difficulties in accessing mental health services, but also inclusive of people who might be intoxicated or under the influence, and ensuring that there is assessment when it's appropriate and when it's possible, and that there's that proactive follow-up. Holistic in the sense that Champreet's just mentioned a lot of those examples. You know, someone might have drug debts, they might have housing issues, they might have financial worries, there might be relationship breakdown. And even though services might not be set up necessarily to respond to those, there is a kind of onus upon services to do some of that collaboration to make sure that people are supported with the needs that might not just be the clinical needs that they have, and then maximizing those intervention opportunities. So, for example, one area we're working with are looking at how the CMHT's crisis service can work with the local addiction liaison team to carry out substance use screening for everyone that presents in crisis, so that they can identify whether there's going to be any future joint working required, whether they can develop a shared care plan, and so that they can get some of that formal and informal advice between services. And similarly, as Champreet mentioned, sometimes people do require admission to hospital. And I guess that also provides a window of opportunity where people might be stable, not using alcohol, not using substances. And there's opportunities there within the discharge planning process and within their care within the hospital setting to think about how you enable that sustainable transition into the community again. And I think I'm really grateful that Emma's here to present on some of the work that Hope Point are doing as a safe space. And I think, as you'll hear through the presentation, the ethos of it really exemplifies some of these principles that are on the slide here. So hands over to you, Emma.
Thank you very much. Pleasure to be here. And this seems to follow on nicely from what you've just been describing. So hi, everybody. My name is Emma Wilson. I'm a Senior Service Manager with Penumbra Mental Health, and I oversee the team at Hope Point in Dundee. So I'm here specifically to talk about what we've been doing locally for the past 18 months or so. So I think first of all, it's really important to sort of conceptualise what we mean, in relation to crisis. A lot of the work that's been going on in Tayside over recent years has looked at the redesign of crisis and urgent care, and the component I'm going to be exploring today is for those experiencing emotional distress. So when we think about crisis and when we've been sort of highlighting the work that we do, we have been looking to differentiate between a sort of mental health crisis, so people who may be experiencing an acute deterioration in a recognised mental health condition, um, as well as then people who are experiencing emotional distress. So those who are finding themselves distressed as a result of the life events and circumstances that they find themselves in at that moment. Now, I had some bits that were meant to slide in here that that are in terms of the text stuff, but on we go anyway. So if we think about the mental health crisis side of things, the crisis resolution and home treatment team are set up to support these individuals. I guess for some time now, people have also thought that they're there to support those people experiencing emotional distress, which isn't necessarily the case when we're talking about life circumstances that does not require a clinical input or assessment of them. So the work really aimed to make sure that there was a parity of response for both the mental health crisis, emotional distress elements, and the work that we've done hopefully bridges that gap, and I'll go on to explore that a little bit later in my presentation. So the journey to get here is actually lengthy, and this slide took me over my time, so I'm going to keep it short and sweet. But I'm sure many of you on the call are familiar with the context in Tayside. There was quite a lot of political pressure for a crisis centre off the back of families who, fairly high profile, were campaigning for a crisis centre after being bereaved by suicide, and also the independent inquiry with the Strang report identifying a number of recommendations, and, a theme throughout numerous of those in relation to responding to emotional distress. So, a number of sort of meetings, crisis and urgent care work, like I say, this is one element of it, but it was agreed that across Tayside, community wellbeing centres should be located. And it was about being sort of bold about this, and, there were several models presented, some of which sat within existing community mental health team services, but it was quite clear from a range of partners, including people with lived experience, that actually this needed to sit with the voluntary sector, and it needed to be accessible and available out with the sort of usual office hours. In tandem to this, the Distress Brief Intervention Programme was being developed in Tayside, so that set up in terms of the pathway with NHS 24 during COVID, and then a little bit later on, Penumbra were awarded the tender to deliver that, looking at other referral streams with the frontline services, including police and SAS. In relation to Hope Point specifically, then, there was a steering group, there was a stakeholder group, a number of work streams that looked to develop the core of the service and what that would look like and what was important to people. Penumbra were awarded the tender for the Community Wellbeing Centre at the end of 2022. I came into post at the start of 2023, and we began sort of setting up scenario planning, working with our stakeholders and recruiting for our staff team. So I think what's really important to highlight throughout the whole process from the beginning is the fact that it has been true co-production, and lived experience has been at the heart of the developments. So thinking about the commission and procurement element, there was somebody with lived experience who sat on the panel that was rating the tender bids and deciding where that would go to. There was the stakeholder engagement in its raw form that was included in the tender submission. We had steering groups and stakeholder groups comprising of people with lived experience, colleagues in statutory services, voluntary sector, up to more senior colleagues in the partnership who were sort of tasked with driving the developments forward. Work streams focusing on specific areas, including the building, the design, the pathways, and what it should look like. The contract and monitoring process has also felt like a sort of element of co-production. I think there's been trust in one another. We didn't know what to expect. It was a new service. So it's very much about learning as we go and allowing that flexibility. And it's been quite refreshing for there to be equal importance put on the sort of qualitative side of things alongside the data and the numbers. As we became operational, then the stakeholder group continued, and so lived experience continued to help us shape the service in those early stages. So we went through a naming exercise and a branding exercise. So the name, hope, point, and the logo that you see on the screen there, that was all a part of the work of our stakeholder group. We also looked at planning an anniversary event that sort of went out widely, and we had great attendance at that, and we looked at ways we could evaluate the service. So they've been heavily involved up until the end of last year when the numbers were dwindling, and actually the feedback was the service is operational, it's delivering as we hoped it would, and therefore we're going to be taking that involvement forward in a different way now, and looking at engaging with people who have been actively using the service to help us devise our developments. So that's the sort of background in a nutshell. It's been a lot. So fast forward to 31st of July 2023. No pressure at this stage, as you can imagine. So we were launching, a soft launch, if we could call it that. 24/7 from the get-go, no referral was required, and people could access support via drop-in, via a free phone number, and via text, and all three of those options are available around the clock. We are in the South Ward Road, so really central location, right at the back of the city centre, the shopping centre, great transport links. And we're also co-located with our colleagues from Hillcrest Futures. So when we talk about that real joint up working in relation to sort of mental health and substance use support, that's been a sort of great partnership in terms of all being under one roof. There's sort of various recovery cafes, social events, harm reduction, needle exchange in the same building. And more recently, there's been further developments with Dundee Drug and Alcohol Recovery Service working out of the same building, and we're in talks about sort of partnerships moving forward. So there has been some great work done there to join those services up, and both parties have undoubtedly seen the benefits of that. So in terms of sort of what we provide, what people can expect, the photos probably don't do it justice. I'm tucked away in a room that probably doesn't do it justice either. But actually what people sort of say first and foremost is the atmosphere feels really calming, it's welcoming. What came through loud and clear from people is that it should not feel clinical. So, you know, down to the colour scheme, the artwork, people were consulted on that. We've considered sensory needs, so the lighting, making sure that it's not too harsh, fidget toys, weighted blankets, soft furnishings to make it feel a bit more homely whilst getting the balance of the volume of people that we see. So that sort of no wrong door ethos is really what we want to achieve. We want people to feel welcome when they come in to see our team. The team are all employed in peer roles, so they all have their own lived experience of varying mental health challenges themselves. As an organisation, we are the lead employer of peer workers in Scotland. So, you know, we've had experience of that over the years, and we decided that we know the value in that, and actually the whole staff team, that's what we were going to recruit to at the start. So when people come in, it's really about allowing them the time and the space to talk about what's going on in their lives and explore what those next steps might look like. If somebody's in a high state of distress, you know, voicing suicidal thoughts and safe planning would, you know, be a part of that conversation, or physically completing a safe plan. As a short-term intervention, we would look at connecting people in with other services and supports if they needed ongoing support. And we very consciously use that term connecting. So making phone calls on people's behalf, putting in referral forms, often advocating on behalf of someone if they have existing support networks or services involved, but for whatever reason are struggling to engage with that. We've been conscious of not putting any sort of time limit or number of visits, so it varies completely per the individual. So some people it might be a one-off contact. for the majority, when we look at averages, it's about 6. So generally people would come back, there would be follow-ups, there would be onwards referrals, connections, we could be looking at self-management resources, etc. I know as part of this webinar, the link was going to be shared for the Safe Space for the Safe Space report. So we are featured in there in terms of a case study of a good practice. So I think our learning and what we found has actually worked well. First off, the peer model that comes through loud and clear, especially when we look at our feedback. When we think about the values of peer work, it's a mutual sort of more mutual relationship. I think it allows our workers to more quickly build a rapport and a working relationship with people, and especially when we're in the service that we are in terms of the nature of the short term of it, it really allows the person to feel more comfortable in opening up in relation to what's going on in their lives. The workers are able to empower, appropriately challenge based on their own experiences, and offer that hope when people are often, going through a really, really dark time. I think sort of closely intertwined then the principles of time, space and compassion, both in relation to the setup, the staff and model that we have. The compassion element comes quite naturally when you're talking about peers who have often been through very similar circumstances. And the environment and the kind of the way that we support people really allows those principles to be embedded. The whole point is inclusive. So really, the person defines their own distress. We are open, we're intended for people aged 16 plus, but we would never turn anybody away. The youngest person we've seen is 12, right up to somebody in their 80s. The substance use side of it, so somebody being under the influence of alcohol and or drugs is not a barrier to them accessing support. We do need to be mindful that we don't have clinical staff on site, so somebody's safety and our staff safety has to be taken into consideration. But if somebody is able to walk and hold a conversation, regardless of any substances they may have been taken, then not a problem for accessing support with us. I think kind of intertwined with that, the accessibility, so the 24/7 element as well, particularly if we're looking at people who are using substances, often very chaotic lifestyles. The traditional setup of services, appointment-based, are really difficult for them to engage with. So actually, people being able to access the support on their own terms at a time and in a way that suits them has proven to be really, really helpful. When we look at the sort of trauma-informed approach, all our team undergo robust training as well. And they come from a variety of backgrounds professionally, including and their own lived experience. But really, it's kind of touched on what was said at the start there. It's about normalising people's experiences and responses to often really traumatic experiences, whether that's been historic or more recent. And sort of helping them to understand, how they are experiencing their current based on what has gone on. And another thing I think that works, we have seen regularly and high volume of new people accessing the service. So the word is out there. And at a time where services are, let's be honest, bursting at the seams in terms of capacity versus demand, we've been able to kind of really promote what we're doing and reach out and encourage people and do that sort of via social media, local networks. Having our our flyers, promo stuff in local community areas. So it is about hopefully getting that sort of friendly tone that encourages people that it is okay to reach out to us. And that could be the individual themselves or the carer. So looking at the pathways and some of our key sort of relationships, I'm going to start at 12 o'clock. We have an agreed pathway and information sharing agreement in place with Police Scotland. So we know from police colleagues that often time has been spent, sitting and waiting on an assessment, spent hours, with somebody because there's no other option at that time. The police cell certainly isn't the right response. The clinical input isn't what's required. So we were very much set up to fill that gap and back to that emotional distress that we talked about. Our agreed pathway means that the police would phone in advance. They would bring somebody along and they would provide a handover. And we're working with police to see how we can capture some data around the time that might be saving them as well, and really the impact it's having locally here in Dundee. The Tay Road Bridge is a local location of concern. We're linked in with colleagues there, so quite often police would be present if it's an incident on the bridge, so kind of joining those dots. But also the bridge staff often come across people that they maybe see quite frequently, not quite at the point of requiring to phone the police. They're aware of Hope Point as a resource and can signpost people to us for support. SAS, we are in the process of firming up a more formal arrangement in terms of the information sharing, but we do link in with them where appropriate. If they feel there's an individual that could benefit from our support, obviously the person would be consenting and they would basically be bringing them along, but we're looking to develop that further in the very short term. We have robust links with our colleagues in Dundee Health and Social Care Partnership. That's across sort of health and social work teams. And I think that helps with often if people have wider networks of support, potentially people with more complex emotional needs, personality disorders, quite often they would have larger teams involved. So the connection and being involved in case conferences, review meetings and things like that would be sort of part of course for what we're doing as well. And finally, we have an agreed pathway in place with the crisis resolution home treatment team. So again, it's bridging that gap. We don't expect Joe Public to differentiate between mental health distress and emotional distress. So it's about having the ability to escalate if there's a requirement to do so. I'd say it's worth noting that actually the number of times that has been required to do so is fairly small in relation to the overall number of people that we see. But it's certainly good to be able to have those links, and that pathway works both ways. So if somebody's in our care, for want of a better word, and we progress the pathway, we're able to be with them for the duration of that, including the assessment, if the person consents to that. And you can see then how having somebody alongside could make it seem like a better experience at a rather scary time for many people. Likewise, the crisis team would say either refer people our ways, whether it's signposting or sending people there at the time if their input isn't required, and actually it's the emotional distress element that somebody requires support with. Our impact, so as you can imagine, there's been a lot of interest. So I send out quarterly reports that do go out widely, capturing some of the data. I'm going to just pick out a few key bits. So here, if we look from our launch date up until the end of January there, the team supported over 1,600 individuals, equating to over 7,600 contacts. So that's a variety of the drop-in text and the phone. We've noticed a bit of a shift with some of these trends as the months have gone on. So phone is the most common way people are making contact, followed by drop-in, and text is lower, I think, than any of us anticipated. When we look at the out of hours figures, that's the average for that time, but actually we've seen a real shift. And when we looked at our latest quarter reports, over 64% of all our contacts were out of hours. The day of the week distribution is starting to look a bit more even. To begin with, it was very much Monday to Friday when people are used to services being open and available. But as we've done more marketing, word of mouth, people are aware it's available around the clock. So we're definitely seeing a shift in that evening out more. When we look at the gender split, as you can see, very equal. That's kind of ebbs and flows slightly each quarter, but we see that as really reassuring when we look at what we know about male suicides locally and nationally for that matter. A breakdown of the age split as well. So you'll see, besides under 16, which we're not necessarily intended for, it's a fairly even age split, with 65 plus being fairly low, although that's something that we are exploring by linking in with appropriate agencies. The reason for contact is extremely varied, and back to, I think, the point that was made at the start, the circumstances why somebody might find themselves at a Hope Point. Quite often relationship difficulties are cited. it might be things to do with cost of living, housing, and actually more often than not, there would be a number of factors that have sort of led to that point of crisis and somebody seeking support. We usually see about 20%, about a fifth of all the people that we see report some kind of substance misuse, use, whether that's drugs and or alcohol. I suspect it'll be higher. That's people who are noting that as part of the reason for their contact with us. And there has been real positive developments locally in terms of strengthening those relationships. So we have been involved in some of the MAT9 work locally. The local sort of one of the local drivers in terms of bringing that forward is the MAC meeting, the Multi-Agency Consultation Hub. I'm sure I saw Jen joining this call, so she's been leading on that. And a real example of good practice in relation to bringing together, there's psychology, community mental health team, we've got voluntary sector, we've got housing, and really quite practically sort of looking at planning next steps for these people. Aside from that, I think our remit is so cross-cutting. We're involved sort of strategically at a number of different levels, mental health, carers, and primary care work as well. I'm now very conscious of my time. I'm going to leave it with a bit about our impact. So we have some feedback questionnaires, which is actually not a bad number when we look at the overall number, although we're looking at how we can increase that. But as you can see from the kind of percentages there, overwhelmingly positive feedback for our first 18 months. I think the quotes there really pull out what we hear from people in terms of what works for them. And it's the peer element, it's the model and the approach, and it's the fact it's accessible, not just for individuals, but for their families during often really difficult times. I am more than happy to be contacted by anybody who wants to chat further, who wants to be on our distribution list, who would like to come along and have a visit and a chat. And thank you very much.
Thanks, Emma. That was a really helpful presentation, and really really good to hear about all the positive work that has been going on. I suppose it does strike me just the number of people that come to you, how many contacts you have, the highest reason being mental health, the small numbers that you have to escalate. It's and I suppose a real an advocacy role that you play as well. And just a warm, welcoming environment. It looks like and sounds like. So thank you very much for that. And there are some questions in the chat box, and we'll come back to that at the question and answer session.
Great. Thank you.
Thank you. I'm just going to now introduce our next speaker. So I'd like Claire McDermott, who's a mental health primary and unscheduled care team leader from the Scottish Government. Claire has worked in various policy roles within the Scottish Government since she joined the civil service in 2000. She's been a team leader for mental health, unscheduled and primary care since 2020. So thanks, Claire. I'll hand over to yourself.
Thank you for that. I'm pleased to see that despite the fact we didn't collaborate on our presentations, Emma, there was quite a lot of read across. So just before I go into talking about the Safe Spaces report that the Scottish Government published in October last year, I just wanted to touch a little bit on some of the unscheduled care work that we've been taking forward over the last few years, because I think that sets the context in terms of the lead up to the Safe Spaces report. And I also just wanted to touch on a few kind of like bigger chunky policy pieces that are developing just now. So in terms of the unscheduled care work itself, the improvements are being facilitated through the Mental Health Unscheduled Care Network. Our Mental Health Unscheduled Care Network consists of some of our national partners, so NHS 24, Scottish Ambulance Service, Police Scotland. We also have representatives from the territorial boards, so the urgent and unscheduled care leads. Sometimes that's health and social care partnership level 2. And we have our third sector services represented in terms of our DBI providers. So the work at the network has really been focused on improving a kind of national pathway for people who need urgent unscheduled care. one that has local links to local areas and clinicians when people need that urgent support. So critical to all of this is, and many people on this call will know, is the NHS 24 mental health hub. So the mental health hub can be contacted on 111 by anyone. They will get through to specially trained staff within the hub who can connect people to a range of supports and services. We'll continue to work with NHS 24 to consider whether it's possible to expand those options. And through the enhanced mental health pathway, the establishment of that pathway has meant that Police Scotland and Scottish Ambulance Service colleagues also have access to the mental health hub when someone calls 999. They need mental health support, but it doesn't require an emergency response. They can direct them to the hub for support. So the mental health hub is particularly critical in the out hours period, as been touched on earlier. In hours when somebody needs urgent support, we would still encourage them to access, contact their GP in the first instance, or if they're open to services, their usual mental health service. But in the out hours period, if somebody requires urgent support, but it doesn't meet the threshold for accident emergency or 999, but they do need to be seen urgently, the hub can refer them to their GP out hours team or to the local mental health unscheduled care clinicians, who will undertake further triage to determine what support that person needs, including whether an urgent mental health assessment is needed. Police Scotland have also got access to those mental health clinicians, so if they are with somebody on scene, those clinicians can help undertake further triage and provide clinical advice on the best care outcomes for those individuals, again, including whether that's a mental health assessment that's needed. Scottish Ambulance Service pathways are newer, but they are available now in most boards. So again, the service is similar to that provided for Police Scotland. And efforts continue to increase the number of those pathways available. So that's a very quick run through of the work we've been doing. Obviously, the programme is much bigger than that. You know, when people need unplanned care, it requires like various bits of the mental health system to work together, including, as already been mentioned today, you know, the distress brief intervention programme for people experiencing distress, you know, crisis services for children and young people, embedding new approaches to suicide prevention, kind of new self-harm training offers, access to older adult services, just to touch on a few. Some of the areas that are still developing, so we are working with Public Health Scotland to ensure that our unscheduled care work is underpinned by robust data. So through the Mental Health Unscheduled Care Network, we agreed a data set which would look at local data to look at who is better understand who is accessing unscheduled care, why, the referrers and the onward care referral pathways. So that pilot has just started. So we've just put out that ask for the first, it's a very royal we, Public Health Scotland have been working with the health boards. And I've just put out that ask for the initial kind of data returns. So it'll be a long period of quality assuring before we get to the point of being able to publish that. But we are working towards that. Another big piece of work that's just been undertaken was a national review of psychiatric emergency plans. So psychiatric emergency plans are used to define roles, responsibilities and procedures locally when somebody's experiencing crisis and are at risk of detention. Following the conclusion of that review, my team are starting the process of drafting guidance on the outcomes of that review, which is aimed at achieving more consistency across health boards, as well as ensuring that pathways are inclusive and it's a gold standard approach when it is detention that is needed. We have also recently, very recently in fact, just earlier this month on the 12th of February, published a framework for collaboration, and the Partnership Development Group also published a collaborative commitments document that sat alongside that. So again, the focus of that is touches on some of the discussion that we were having earlier. You know, not everything's a clinical response, really focused at people who are experiencing distress, ensuring and building on that multi approach, one that kind of minimises service boundaries to ensure that people get the care and support that they need. And the collaborative commitments document that sits alongside that outlines a range of activity that will help us to achieve the aims set out in the framework. So given the theme of today's session, I also wanted to touch on people who are substance affected and experiencing crisis. So I think one of the biggest challenges that we see in the unscheduled care settings is people who are deemed too intoxicated to participate in an assessment. This has been discussed at our network a number of times, and I think there's broad agreement amongst members that that should not be on the basis, you know, an assessment should not be refused on the basis of somebody having consumed substances or alcohol. It should be based on their ability to or capacity to participate in that assessment. But we are keen to look at what we can do, particularly following the publication of the protocol, to look at what, you know, how can we improve our kind of current unscheduled care pathway, particularly thinking about proactive follow-up when somebody has not been able to participate in an assessment, but also looking at some of that upcoming work and where there might be opportunities to improve how we support people who are substance affected and in crisis. So the psychiatric emergency plan review that I touched on, it's the guidance, we anticipate the guidance for that will touch on kind of local roles and responsibilities, the support and proactive follow-up that should be in place for people who are at risk of detention and experiencing crisis and substance affected. We're also doing a bit of work around, it's just scoping at early stages, looking at people who frequently present in crisis. So our Scottish Ambulance Service already have supports in place for people who frequently contact their service, but they are not the best service to respond. So they instead support those individuals to connect with local services to better support their needs. So we are looking at how we build on that. And if we can build on that and learn from that approach across our other NHS 24 Police Scotland services, for example, that provides us with opportunity to share better information, improve joined upness and the support that we provide to individuals, and taking us into safe spaces. People who were substance affected and in crisis was something that came through a lot during the development of the report. So I will move on to talk about that now. So despite the improvements that I've just talked through, it was clear from our discussions with partners that safe spaces is something that was unanimously agreed on as something that would enhance the support available to individuals who might need unplanned care, or at least a proportion of those individuals. So the report explores the feasibility of implementing additional safe spaces as an alternative to people being conveyed to ED, but probably more so actually people who wouldn't be, but would benefit from a community-led service. I'm not going to go through all the findings of the report today. It's quite a lengthy report, so I will just cover some of the key things that came through for me, and also just take the opportunity to say that we were really grateful to the service providers who exist across Scotland just now, who gave us their time and expertise to help inform the report. Emma, I'm very grateful to you and your colleagues for the time that you gave us to speak to us about Hope Point and help inform the report for the Hope Point perspective. The definition of a safe space was the first thing that we looked at. I think there have been a lot of recommendations that said that we should have safe spaces and described them in a variety of ways, but didn't necessarily break down like who they were for or what they might be for or when they might be for. And one of the things that came through was that they shouldn't be in something that's replacing clinical mental health interventions. They should be something that's additional to that. And that includes the emergency department. There's still a role for the emergency department to play when that is where somebody needs to be cared for. But the report also acknowledges the evidence that the emergency department is not always the best environment to support people's recovery from crisis. And that is where other kind of alternatives can be of benefit. It also came through that purpose needs to be considered alongside the needs of those who require a safe space. So again, that they can not always be the same thing for all people all the time. So trying to do everything for everybody all the time is quite challenging. So the report has talked about the notion of a tiered approach. So you might have clinical services where, for example, somebody's at risk of psychiatric admission, or where there's an acute mental health need, but there's no consent to that support being provided. But also looks at the benefit which Emma's talked through in terms of the Hope Point service, and particularly that peer-led approach and the range and variety of supports that can be provided by a community-led service, and actually came through that the two need not be exclusive. I think Emma talked about the really good pathways in place when people do need clinical support from a community-led service, and likewise that peer support's not something that necessarily needs to be just kept to community-based services, that there's evidence to suggest that they're actually very beneficial in clinical settings too. So in terms of function, so to reduce the need for statutory measures and improve outcomes for individuals, particularly in bridging that gap between admission to hospital and safe to leave at home, the report touches on the function of a safe space and the variety of functions that they can provide. So, for example, a non-specialist safety monitoring, to provide non-specialist safety monitoring and planning over an acute crisis phase, a comfortable space to be monitored and remain safe while intoxicated, a comfortable space providing a range of supports and interventions, an alternative to the legal place of safety, a calm therapeutic environment for specialist support, assessment and treatment, an environment for longer term assessment and monitoring to determine whether hospital admission is needed, and the ability to connect people to a wider range of services. And that list is not exhaustive and not necessarily exclusive of each other either. In terms of who services are for, the slide touches on kind of broad cohorts of individuals, but actually the report goes into much more detail around meeting the needs of people with protected characteristics, people who might be experiencing severe and multiple disadvantage or stigma, to ensure that the design of services and operation of services meet their needs. I guess the other thing that came through is some services do exclude young people who are intoxicated and people with disturbed behaviour, suggesting that there might be a greater need for services for people in that cohort. Button. And finally, the report touches on protocols needed to operate safe and effective services. I'm not going to go through all of these. It was just to give a flavour of some of the things that the report touches on, and the degree to which these are needed are likely associated with the level of need that the services are supporting as well. As Emma noted, there was some good practice examples of services already operating, covered throughout the report and referenced throughout the report, and the annex covers a greater range of those services, demonstrating the variety of models and services that are currently operating. One of the biggest challenges that came through in the report in terms of implementing safe spaces was the challenge around geographical demand. So, if you've got low demand in rural areas, for example, the feasibility to operate in a 24/7 service, which is fully staffed, becomes quite challenging. So noted the need for a flexible approach that can be moulded realistically to local demand and resources. So in terms of conclusion and next steps, as I said, the report has been published. I think what we would like to do as a team just now, and what we are considering, is whether we can take forward a cost-benefit analysis of safe spaces. I think what the report that's published does is make the case well around the benefits to individuals of increasing the availability of the services, but we think a good next step would be making the economic case. And we would also like to pull together a toolkit that could be used for the implementation of new services. Health Improvement Scotland colleagues have helpfully and kindly agreed to share the links to the Safe Spaces report that I've talked about, as well as the Framework for Collaboration and Collaborative Commitments plan. So those links should come following the event, and I will stop there.